Welcome to the Visceral Voice Podcast. I'm your host, Christine Schneider. Through this podcast, I aim to bring you the most current, up-to-date research on voice science, function, pain science, movement, and everything in between. I am on a quest to learn everything I can about the living, breathing body and its intricate connection to the voice. This podcast documents the continuation of my learning and my experience as a professional singer, a nutritional consultant, a movement specialist, and a manual therapist. Join us as we strive to provide current, knowledgeable, creative, and compassionate information to help you restore, regain, and create happiness and success on your vocal journey. Dr. Kathy Dooley is a chiropractor practicing within Catalyst Sport, the gym that she co-owns. Dr. Dooley is an anatomy instructor at two New York City medical schools, the Albert Einstein College of Medicine and Weill Cornell Medical College. She is an adjunct professor at New York University's College of Dentistry. She is a visiting professor for St. George's University Medical School in Grenada, West Indies, and she assistant instructs in the Gross Anatomy Lab at New York College of Podiatric Medicine. She is also a lead instructor for two seminar series, NeuroKinetic Therapy and the Immaculate Dissection. I am really stoked to have Dr. Kathy Dooley on this episode today talking about over-cuing of the posterior pelvic tilt. So here you are, my conversation with Dr. Kathy Dooley. Before we dive into our topic, I would love for the listeners to know more about you. You have so much experience. You're a chiropractor, an acupuncturist. You do neurotransmitter therapy. You teach anatomy at several universities. So tell us a bit about your journey, who you are, what you do. Let the listeners know a little bit more about you.
Oh, sure. I never loved putting people into boxes like in life and in business, but the box that most people would put me into is a chiropractor. I think that when people come to see me, they find me to be very non-traditional of sorts. The rack-em, crack-em kind of chiropractor is not what I am. So what I love about chiropractic is the autonomy given to the doctor, where we do a lot of nutritional counseling, movement counseling, manual therapy, hands-on, hands-off. In this world of telehealth, I'm certainly glad that I have developed systems where I'm not needed. And my big goal in life was that my body, I didn't feel right with my body when I was in my 20s, probably ever, until I started to find some really great people in movement therapies that made me accountable to myself. And one of the ways that I found when I was going through chiropractic school, I started to feel worse. All my orthopedic problems felt worse. My athleticism was really high, but I just felt injured all the time. And I'm like, this cannot be the solution. There has to be more than just putting a Band-Aid on people by getting them out of momentary pain. I gravitated towards some really amazing mentors that put me towards neurodevelopmental movement, kettlebell training, looking at things from a functional movement perspective. And that was life-changing. Then I started to do more studies into trauma processing and neurotransmitters and how my neuroscience background would play a part in the way I watched people move. And I started to find that I was looking at people in this massive holistic lens for which I was trained, but less of the popping, clicking, and getting people into this 10 minutes of GABA relief that they would get from an adjustment, and more into, not that that's not valuable, of course it is, but more into a holistic viewpoint of how one can help oneself. So if you were to probably encapsulate what I do with my patients, it's about empowerment, about trying to help themselves first and foremost. And for me, that meant being more hands-off and more encouraging them to be able to help themselves. And that's when I developed the Immaculate Dissection coursework, which I think you've taken some of it, the ID Collaborative podcast, where we do lecture hours on different topics, and just trying to inform and educate and making sure that patient knows that they are a lot smarter than maybe a lot of people have given them credit. And that is really the impetus of what I think I do for a living.
People are always asking me who my mentors are. And that's the wonderful thing about the podcast, is that you get to meet some of them. And through this very strange time of the pandemic right now, where a lot of things are virtual, I haven't met a lot of my mentors, but Dr. Kathy Dooley is certainly one of them. I really appreciate all of the work that you're doing, the knowledge that you're putting out
Thank
there
you.
for other practitioners. So thank you for your work. And I am super excited to chat about over-cuing of the posterior pelvic tilt. So in our movement sessions and personal training, in dance classes, in Pilates classes, in yoga classes, people are constantly hearing to activate the glutes, activate those abs, tuck the pelvis, squeeze as if you have $100 bill in between those glutes. We're hearing
Yes.
all of these cues that are cueing into a posterior pelvic tilt. And I would love for you, if you don't mind, to chat about what's happening when we're cueing this, the
Mhm.
anatomy and neural tensions, etc. What's happening at the lumbosacral joint? Just
Mhm.
fill us in. What's going on, and why should we not perhaps say some of these cues?
Okay. First, I like to turn the question around on the person that's doing
Mm.
it. So I have a lot of patients that are cued into exactly like you stated, that gluteal concentric contraction. Uh, I'm sorry to laugh. It's very odd to me that this is cued. The What they want, I get it. And I want to ask and make sure I'm right first, because I like to turn the question around and then I say, why do you want to posterior pelvic tilt? And they inevitably say, well, my glutes will activate. My glutes are really strong. I go, great, okay. And then why do you want the abs on again? And they're like, oh, well, it's good to be strong in the abs. And then I said, okay, why? Why do we want to be strong in the glutes and strong in the abs? Well, to keep, it inevitably always comes back to people saying keeps the spine safe. And I said, well, what if I told you that's not accurate?
Mm.
That that isn't actually what happens. So it does come down to the anatomy, and the anatomy is the best way to explain why to not overcue it. So I'm glad that you asked this very important question. People want abs because they think it protects their back. Stu McGill's research has kind of shown that with transversus abdominis. Diane Lee's work with transversus abdominis. All these great researchers have pointed towards that. But neither one of them cue the posterior pelvic tilt. And so I started to really think about the anatomy of it. I'm like, okay, what is it that people think that they're doing? Well, they think if their abs are strong, that the low back will lose some of this excessive mobility, maybe, right? Because the lower lumbar spine is the most mobile part of the lumbar spine, and it is the least protected. From L4 to S1 on the front of you, you have no musculature really protecting you. Why? Is it because we're the product of nearly 4 billion years of evolution? Why is there no musculature between L4, L5, L5, S1 to really anchor down those segments? It's because you're sacrificing that stability for mobility. We want to be able to have a center of mass where we can change direction. We can be able to orient ourselves on multiple planes. And that is initiated with a lordotic curve, which, for any newcomers to anatomy would mean a curve towards the anterior with an apex typically between L2 and L3. If that's true, that lordosis is maintaining this really good stability over the lumbar spine, that must mean that the sacral and thoracic primary curves that are kyphotic, they move towards the posterior, would then encourage us to then build a cervical lordosis. Why do we do this? Why do we have a low back and a neck that bend towards the front and a thorax and sacrum that bend towards the back? Well, it's to create an S shape in the sagittal plane. And that helps us to decrease axial compressive loads from gravity and ground force contact by 3 to 5 times. So we want this curve, right? We want this buttressing of force. Not only do we want that, but because that we have the lumbar vertebrae are wedged to be larger on the anterior than on the posterior, likely because of this time spent in lordosis, we also know that creates a good space to happen between vertebrae on their lateral sides. And this is where we have the intervertebral foramen, where there's a hole where the spinal nerves come out and then end up all the way down to the bottom of your foot in the lumbar spine, right? So we know the bottom of the foot's largely controlled between L4 and S3. If that's true, we want this nice load shared space between vertebrae. We want to be able to maintain a lordosis, and we never, ever are going to completely lose our lordosis. We're only going to be flexing, to decrease some of the degrees of it. But we want to be able to keep that space open, and we want to be able to intersegmentally stabilize an area that's, by nature unstable, which is between L4 and S1, our center of mass. And this is created by the muscles multifidi lumborum. Multifidi lumborum are the only muscles that are really deep intrinsics that are controlling intersegmental movement of the lumbar spine. When you excessively posterior tilt to feel your abs or turn on your glutes, you actually are decreasing the degrees of lordosis and actually limiting the total amount of space where the nerves are coming out between the foramina. You're also putting the multifidus into a partially stretched position, which can encourage stretch weakening of these intersegmental stabilizers. So you end up doing the opposite of what the goal was, which was to create more space for the nerves to be able to protect your lumbar spine. Pushing the low back into the ground is not an efficient cue pretty much in any position. And a lot of people, my athletes that are gymnasts, they'll do it with hollowing. They're taught to push the low back into the floor. Some of my traditional Pilates instructors that take my coursework, they find it really difficult that I don't want them to push the low back into the floor. And because the reason why they're told to do it, I think, was to prevent excessive lordosis, to prevent an excessive anterior tilt that would jam the facet joints and then decrease the activation of something like multifidus and then trade it off for erector activation. I totally understand that. I think it's over-cued, like you stated, where people are then, it's like a little bit becomes a lot bit. you end up turning off the things that you want to turn on. The more you stretch, weaken multifidus, it won't be able to intersegmentally stabilize, and you'll be able jamming the facets. When you start jamming the facets, the foramina becomes stenotic. They start to lay down more bone. As you jam bones together, you lay down more bone, and then less space is available for the nerves to come out. So that glute that you're trying to activate with the posterior pelvic tilt, you can think of it as choking itself and its nerve supply. Every time you overly squeeze the glute and posterior pelvic tilt, you're putting a chokehold on the nerve pathway. And that can be not a great thing for the longevity of the gluteus maximus. Also, the gluteus maximus is the strongest muscle of the human body, right? By far. It has a very long tendon attaching to the tibia. It's attaching to, part of the PSIS, sacrum, sacrotuberous ligament, and then, 25% to the femur itself. It's such a control freak. It has to centrate you as well as force generate you. And the gluteus maximus is not meant to be in this iso hold for these prolonged periods of time. It's a force generator, not a major joint centrator. 75% of its job is to force generate, which means it's like pulling a rubber band back and firing it. If you want powerful glutes, the worst thing you could do is contract them isometrically for prolonged periods of time and they burn themselves out. The best way to do it is to isometric or to isokinetically move from an eccentric to concentric position. So you actually won't strengthen the glute max properly with just constant iso hold. And also, I argue you would leave the body very vulnerable to back problems that we described, facet joint jammings, intervertebral foraminal stenosis, when you do that position of pushing the low back into the ground. And I've had several patients, this isn't just me talking anatomy, this is actually very much supported by the research of Diane Lee and Stu McGill, but also in my empirical data of my clinical practice. I've seen people where I take them and say, hey, ASIS, PSIS, front and back of the pelvis, relatively even. We know it's going to bias a little bit more towards an anterior tilt because we have a lumbar lordosis and the lumbar spine articulates with the sacrum. So there's going to be a natural little bit of nutation because we're a biped. We're a biped, so there's naturally going to be a little bit of movement forward. We want to counter that a little bit, maybe just by cueing the person to not be hyperlordotic, but you certainly don't want them to be the ASI is higher than PSIS, and then eccentrically loading, this multifidus So where it can't concentrically control the intersegmental movement of the lumbar spine. I do think that that cue encourages people to earn a back problem. The whole reason they're trying to do it is to turn on their abs, to turn on their glutes and prevent a back problem. It always comes back to that. So if you turn the question back on the athlete or the client and say, why are you doing it? I was told to do it by my trainer. I was told to do it by my PT, my Pilates instructor. Great, fine. Why are you doing it? Why do you think you're doing it, patient? It protects my back. And well, it actually doesn't. And then I have this whole conversation with them. I've had this conversation so many times. So when you asked the question, I was like, I'm so happy to say it because I think the repetition is good for me to hear. Like I was coached into that for years and it did not help my back problem.
And yeah, I was also coached into that.
Were you?
And
okay.
I was a runner. I was running marathons and I would do dead bug, pushing my low back into the floor. So you couldn't pull a piece of paper out. That's what I was told.
Yes.
And I would get up and I could hardly move.
Right.
And I'm like, how is this helping my running? Now, as I'm working the intrinsic stabilization subsystem, very much in the ways that you discuss in some of the coursework I've taken with you, it's such a different experience. Yeah. First of all, I'm able to breathe while I'm actually doing a dead bug or a 90-90, coming into crocodile breathing. It's so incredibly helpful to actually allow this to maintain some of that lumbar lordosis. I just think it's so important.
If you're going to minimize it to a very short conversation, let's say you don't have like the 15 minutes I just took to explain the anatomy of it. All you have to do is say your lumbar spine tend towards lordosis. You are, it's not even functional at the point of where you're an adult. It's structural. The vertebrae are larger on the front than they are on the posterior. So you are going to bias towards lordosis, right? It's good. It's helping you decrease the axial compressive loads. It's very good to buttress ground force contact. It's good for all those reasons. All I do is walk the patient over to the spine and I show them, like I have a skeleton hanging in my office. I show them the curve and I say, this is really what we want. If we straighten it out too much, we train you to straighten it out, train you that that's a good thing. Like you do your dishes with a posterior pelvic tilt. Like it's not going to be great for the longevity of your spine.
Well, and that's what training is all about, right? Training is about either healthier movement through our everyday life or movement for whatever sport that that individual is actually working towards. So in their training, it has to look like their sport.
Yes.
So, and that's true with everyday movement too. If you want longevity, you train for that longevity.
It's not shocking. It's really not shocking. I think that they are taught to believe that a posterior pelvic tilt increases longevity, much like you and I were. And it's just not true.
Yeah, you had mentioned the space that is needed for the nerves to come through. Can you talk a little bit about how the nerve supply, how much of that 90%, I think is it 90%?
Vast majority. There's some, of course, lumbar plexus nerves that stay, like hypogastric nerve plexus, iliohypogastric nerve stays pretty much in the abdomen, but the vast majority of them do, yes, enter the lower extremity. The foramina, like they really remain patent in this lordotic position. And as long as you're load sharing through the lumbar spine and quality tendency towards extension, you're creating good space for the nerves to exit. And I do think that if you cue a posterior pelvic tilt or if you're hyperlordotic, both extremes, that's how you start to jam the joint surfaces together improperly and develop stenosis. And the most common places for intervertebral foraminal stenosis, the nerve exit point stenosis, is between L4 to S1. When I see patients with discogenic back changes or lumbar stenosis, it's almost always intervertebral foraminal, and it's almost always between L4 and S1. And if you think about it, that is not a place you want to mess with. Like the gluteal region, the hamstrings, the calf, like a lot of your major drivers of human movement for propelling moments are on the posterior chain, and they're innervated by L4 to S1. We say S1 on the bun. And I also don't want to mess with L5 on the side. Like the L5 nerve root is controlling femoral centration and trying to buttress the adductors that are largely innervated by L2. So if you want to stay stable, not even just mobile, if you want to be stable and not develop weird discrepancies, you better protect the L5 nerve root. The L5 and S1 nerve root are very susceptible. So to me, it like does not make sense to push your low back into the floor. You are, I mean, I don't know if any of you folks that are listening have ever treated somebody with a facet arthropathy between L5 and S1. It's way more painful than disc herniation for most people. Those joint surfaces jam together. And so they're often cued to do a posterior pelvic tilt to ungap the facets, right? Then what happens to them is they I had a patient that overstretched their facet joint doing this cue from a physical therapist, very well-meaning, well-intentioned physical therapist. The patient just took it too far. The PT didn't even know. This person was sitting all day or standing all day at a standing desk in a posterior pelvic tilt. She stretched the capsule out. She created a decompression of the L5S1 capsule, and she had to get prolotherapy for 6 months in that segment to not have back pain every single day. And it was like $5,000 later, like it was just like a really expensive time and effort just because she took one cue too far. I think you can take that cue really too far.
There's an image that Dr. Evan Ozar has. I think it's even in some of his books. He's written 2 books, The Pelvic Solution and Corrective Exercises for Hip and Shoulder Dysfunction. And there's an image there with 3 AFAB folk, one in their 30s, one in their 50s, one in their 70s. The one in their 30s has that ASIS slightly lower than the PSIS. The one in the middle in the 50s, it's very level. That pelvis is very level. And then the one in the 70s, that PSIS is slightly lower. So the water would be coming towards the back of the pelvis.
Yeah.
And this is to represent what you had just mentioned, that spinal stenosis. As we age, we see a lot of people with spinal stenosis. Is that normal aging, or is that something that's happening because we are over-cuing the posterior pelvic tilt? What do you think?
I don't think it's the latter at all. I think that, first of all, it's slightly erroneous. There's not peer review that really supports that claim that you're destined to become stenotic as you age. It increases in correlation with aging. So I see people of a huge population gamut where I have not particularly noticed that aging, and definitely with AFAB people, ends with stenosis. And I see people from age, 3 to 90s. I think that what happens to people is they lose strength. They lose strength when you're talking about AFAB, you're talking about postmenopausal women too, the effects of menopause and the ability you lose your androgens in this huge way. So building muscle tissue becomes really hard. And when muscle tissue is lost and then not maintained consistently, like fighting this losing battle, if you're not really training to counter that, you're going to end up not being able to activate things like multifidus, activate things like the gluteus muscles, the hamstrings, quads, the abdomen. And then you end up with a more straightened type of curvature in the lumbar spine that's non-lordotic. I see what your point is, though. If someone's assigned AFAB and Evan Ozar, is this incredible person, has noticed this in his empirical data, it would beg the question of not pushing your low back into the ground. If it's going to happen to you anyway, you certainly don't want to encourage it. But I think what happens in postmenopausal females is the big change in androgens. I should just say estrogen is also progesterone, but in all androgens, you end up with a change in body fat deposition, a change in the ability to build muscle mass, a change in bone density, and you have to fight those with quality, well-balanced training, or a tendency may arise, as Dr. Ozar probably found, where the person starts to develop more stenosis. And stenosis, it's not just AFAB, it's also the people assigned male at birth, because they will tend to also lose their muscle mass and they start to become osteoporotic. And the numbers for osteoporosis start to match in males and females assigned at birth after the age of 70. So we end up, males have 1/3 of all the hip fractures and nobody talks about it. We assume it's just females. And so I think that it's more to it than just the cueing of a posterior pelvic tilt. I think that you do notice someone with central spinal stenosis, which is different than intervertebral foraminal stenosis. Someone with osteoarthritic changes in the center of the spine develop a posterior pelvic tilt. You almost always see them in that posterior tilt with that weird kind of hunch where they're kind of hyperkyphotic and they shuffle with their feet because they've lost their power. It's just one more reason to not make that cue. I mean,
Mm-hmm.
I have to side with Dr. Osar. I think that observation has its limitations, of course, but I think his point is very good that keep the muscle mass you have. Make sure you're maintaining your lordotic and kyphotic curves with load share. Make sure they're even for your whole life. Make sure to decrease what aging will be correlative to do to those lumbar curves, and then encouraging stenosis might be inevitable if those changes occur.
Fontis lozenges provide moisturizing relief from dryness with a unique formula that stimulates saliva production to assist with dry mouth as well as the recovery of hoarse or strained vocal cords. Fontis offers a unique blend of green apple extract and glycerin to assist in saliva production and manuka honey, which contains antibacterial and anti-inflammatory properties to promote healing. Fontis were made with love by Caitlin Hopkins to help anyone who needs relief and is suffering from dry mouth. Please contact us at The Visceral Voice to purchase your bag of Fontis today at thevisceralvoice@gmail.com. Physical therapist Christina Christie, she is with the Gray Institute, and she talks about the stacking mechanism, the importance in the AFAB of the pubic bone with the bladder stacking on top, and then the uterus, and then the rectum behind it. And so I was wondering if you would chat a little bit about the differences between AFAB and AMAB pelvises. Obviously, there's spinal stenosis and osteoporosis, everything happening in the AMAB pelvis as well, and centration. What are the differences of AFAB and AMAB pelvises first? And then second, with any kind of athletic performance, with the training, is it more important then that one, say the AFAB pelvis, if we have this stacking mechanism that is important for our organs, is it even more important for us to really be mindful of that cue with the AFAB pelvis?
First off, the AFAB pelvis is going to be dynamically different because of the presence of the uterus. I know you folks probably already know that there's a urinary bladder behind the pubic symphysis, the most anterior part of the pelvis. Posterior to that is the uterus, which typically is anteverted, anteflexed relative to the urinary bladder, and then posterior to that is the rectum. And people that are AMAB, they don't have, of course, the uterus. The membranous tissue at the bottom of the pelvic floor and the urogenital diaphragm is different too, because of the presence of a phallus in the male. Means that there's a root of the penis, and there's the urethra running through the spongy part of the penis. And then the females, of course, don't have that. They have a vestibule, and people that are assigned female at birth will have an open hiatus. Basically, the urogenital hiatus in the people that are AFAB and AMAB are very different because of that presence of the vaginal opening. This is very, very clinically significant because this means that there's more width created in people that are AFAB. So as the body is developing, we call it a gynecoid pelvis, where there's a more obtuse angle at the infrapubic region. And this allows for the vaginal opening to encourage the passage of a fetal head, right? So if that width is present, then it propagates the species with efficiency with vaginal birth. In people that are AMAB, this urogenital hiatus, the area where the vestibule would be for the vagina, is closed off with membranous tissue, which means that their infrapubic angle is more acute of an angle. Why does that make a difference? It makes a huge difference because remember that you have the lumbar spine articulating with the sacrum. And the sacrum now is on a base of support that has pubic bones as part of the os coxa set a little wider. Well, why does that matter? Because the three bones of the pelvis that make the os coxa, the articulation for the acetabulum, the articulation for the femur, is now much wider relative to the spine, which means with every step that we take, it changes the dynamics of what's happening at the pelvis relative to the femoral head. In the people that are AMAB, it's a more narrow setup. And so one would argue it's easier for people to build external rotational forces and put an eccentric load on the pelvic floor if we're able to externally rotate more when we have a wider pelvis. So women have this, people that are assigned female at birth have this width, but also more ability to build a bigger contraction through the gluteal region. And that is kind of like the bonus of having a wide pelvis. Your ability to build force is greater. The problem that comes with it is now a more a bigger Q angle, a quadriceps angle at the femoral shaft. And so we will tend to have to build more strength in order to maintain an upright position relative to the spine. So it's just one more reason why people that are AFAB have it a little tougher. We don't have as much, people that are AFAB don't have as much testosterone to help us recover from muscular activity. We do have androgens, but for us, it's going to be, we are just more based towards slow twitch, and it's just harder for us to create the stack, but more important for us to create the stack. What Dr. Christie is talking about is really, really important because you have to really fight for your ability to build strength if you're AFAB. If you're AMAB, it kind of comes a little bit more naturally because your base is more narrow and there's just less room for error. And but I would argue you have a better, greater chance to, if everything is perfect, to build more total strength and power if you have a wider base. And it's kind of like when someone sumo squats versus conventional squats, or sumo deadlifts versus conventional deadlifts. A lot of people can pull way more weight when they're in a sumo position because it's wider, because they're able to get more total recruitment from the lower extremity. Plus, there's less total distance to go from the ground. And I always think about that when I think of AFAB versus AMAB. It's like you are born with these notches against you and then potentials to build more than the other person assigned at birth. So, the people that are AMAB, they get more testosterone, but they have a more narrow base. The people that are AFAB are wider base, but have more potential to build power. So it's like, with both sexes, it's very, very important. For both assignments, it's very, very important. But I'm very, very proud to be born AFAB. I think that it is a tougher situation probably when you're in the initial phases of earning your body's orientation and awareness. But, like 60% of my population for treatments are males, and a lot of them have pelvic floor problems. A lot of them have things that are just not as discussed as it is for females. So I think that I'm very proud to be AFAB and be able to have a good understanding of the importance of both assignments having proper stacking and proper positioning. I do think you have to account for the gynecoid versus android pelvis and the difficulties that may arise in the appropriation of the stacking. But either way, whether you're AFAB or AMAB, earn it. Earn it. And nobody gets a pass in my office. Everybody has to follow the cues of stacking. For us, stacking is called neck long, chin tuck, chest wide, ribs down, hips even. Getting everything to stack up properly, and then, not accentuating the anterior tilt, not accentuating the posterior tilt, but letting the body fall into a place that's really neutralized for that person, whether they're gynecoid or whether they're android pelvis.
I love that. I love your cues. I use your cues in my training. They are so incredibly helpful for me and for my people. And something I also really love that you talk about is talking about equal load share through the diaphragms as opposed to posture. I know I'm straying from our posterior pelvic tilt
No, it's
a little bit.
fine.
However, it's super important as we're talking about what is, quote, posture. And I sort of changed my language around this after I took your class to an equal load share through the 7 diaphragms. So if you want to
Awesome.
run through any of that,
I'm
I'd
fine.
love
Yeah,
it.
I'm happy to. So, a lot of people know the 7 chakras. If they've taken any, yoga or Ayurvedic medicine training, they talk about these 7 places of energetic accumulation. We talk about it in Chinese medicine. We call them, something different. But when I started to think, I really thought strongly about it when I was getting my anatomy degree. I was like, why? Why these 7? What is so special about it? These people, this is 6,000 years of staying power with Ayurvedic and Chinese medicine. There must be something to this. There must be something anatomical. For me, it's always about the anatomy. So I started to do the deep dive and look, and I was like, oh my gosh, there's 7 anatomical diaphragms. I was like, oh geez. And what is a diaphragm? And most people know the thoracic diaphragm, right? And the thoracic diaphragm is your primary muscle of inhalation. People know it as this structure that's underneath their ribs, and it separates the thorax from the abdomen, right? It has some passage points, 3 major passage points for viscera to pass to and from. So a diaphragm is a septation area. It blocks things from going from one area to another, but allows a passage. And there are 7 ones in your body. And I the day that I discovered that for myself, and I'm not the first to discover it. Obviously, it's been known since the dawn of human. But I was like, whoa. Has no one really described this in toto? The best I could find was the osteopaths had described 5, and I was like, close, but not complete. And as I looked, they almost line completely up with the 7 chakras. I was like, wow, that's so cool. So the first one is the diaphragma sellae. The diaphragma sellae is a piece of dura mater that separates the hypothalamus from the pituitary. And if you've done any studying on the HPA axis of the body, which is huge in research right now, everyone's studying about HPA. HPA stands for hypothalamus pituitary adrenal axis. It's basically your chemicals, your hormones, like the way that you are orienting pretty much every single chemical compound in the body. And the hypothalamus is responsible for, fight, flee, feed, and fornicate, your 4 Fs. And it sends chemicals, releasing chemicals down to the pituitary, and the pituitary then manages basically every endocrine function of your body, right? Very, very important axis. And so they're separated by a diaphragm, a piece of dura mater. And it's anatomically pretty close to be located where the third eye is. People talk about the pineal gland and the third eye, basically right above your eyebrows and in the center line. Well, that's very close to the anatomic location of the diaphragm 1. So I was like, oh, that's interesting that, what they've been talking about for years with the third eye has huge anatomical basis, not only in the thalamic part of the pineal gland, which is epithalamus, but also hypothalamus. I'm like, wow, that's thalamic. That's a huge deal. Diaphragm 2 is a septation between your nasal cavity and your oral cavity. So it's basically soft palate. And so if you think about it, when you breathe in through your nose, you said you had a lot of people that do vocal instruction on this talk. Mm-hmm. So you guys already know, raise the palate. And you're basically trying to open that airway and get sound to move from the nasal cavity into the nasopharynx, and then eventually into the oral cavity and larynx, and to be able to help you to get air in and out. And the soft palate's helping to manage that. So it's a diaphragm. The diaphragm 3 is the floor of the mouth, the mylohyoid area. So that's managing things that go from the floor of the mouth to the neck. Diaphragm 4 is your sternoclavicular joints, like the base of your neck. So it's where your first thoracic vertebrae kind of meets, and it creates an articulation with the first rib, and then the first rib makes a joint with your sternum and your clavicle. So that's separating things from neck to thorax. Then you already know diaphragm 5, which is thoracic diaphragm, from your thorax to your abdomen. Diaphragm 6 would be the pelvic diaphragm, which is levator ani and coccygeus, which separates things from abdomen into perineum. And then, of course, you have your perineal diaphragm called the urogenital diaphragm, which we mentioned earlier, which separates things from the perineum to the outside world. So they're numbered in reverse in the chakras. They start with 1 being at the root chakra at urogenital diaphragm. And for us in ID, we name them from top up down, just for the sake of starting at the top and ending at the bottom. And what we teach in our, and you've taken our ID6 coursework, we I was like, wait a minute, how can you harmonize all these diaphragms at once? What do we cue people to do? To harmonize all of them so we can get central line stabilization in the sagittal plane. Let's face it, we live in the sagittal plane. We're not crabs. We need all of these diaphragms to line up and basically communicate with each other. Well, how do we do it? Eyes lasered forward on a target, lips together, teeth apart, tongue on the roof, neck long, chin tucked, chest wide, ribs down, ASI is PSI is relatively even. Boom, you got your 7 diaphragms. So anytime I teach a course on pelvic floor, anytime I teach a course on hormones, anytime I teach a course on breathing strategies, on shoulder stabilization, on pelvic floor, on urogenital control, menopause, I give those same cues. I'm a broken record because I know that those 7 diaphragms are the first and foremost importance for us to get central line stabilization in the sagittal plane. So if I'm going to fight gravity and ground force contact, and I want all those things to line up, it's eyes lasered forward on a target, lips together, teeth apart, tongue on the roof, neck long, chin tucked, chest wide, ribs down, hips even. And I tell you, it sounds long. It's not. People do complicated things, way more complicated things all the time. So for me, right before I do a pull-up or a push-up or whatever I'm going to do, a get-up, I'm just making sure all those things are lined up. And the moment I lose those, the tendency to come off of center is going to increase. So it should be probably slowed down at first until people get used to it. But then probably like you've noticed in yourself and your clients, it helps.
It helps so much. And I slow it down for people for the first 3 times or so. And then I've started going through it like you do, where it's much faster because they've heard it before. But it's a reminder. Right? Yeah, exactly.
People ask me all the time, like, what's your mantra? Like, what's your mantra of life? If I had to pick, I have 2 mantras of life. One's mine and one's from Brett Jones, this amazing ATC he's the head of Strong First. Mine is, of course, you just heard it, eyes laser forward on target, lips together, teeth apart, tongue on the roof, neck long, chin tucked, chest wide, ribs down, hips even. And that is my mantra for all of life. If I'm stressed, if there's turbulence on a plane, it puts me into the task positive network of my cerebral cortex. So boom, it's something to focus on. It gets you out of anxiety, out of stress, and into harmony of the 7 diaphragms. And it's my go-to. It's my personal motto. And I don't want people to deviate from that if they can pull themselves back to it. When I deviate from it, I just say my mantra and go right back to it. If I have a bad repetition on a workout, if something's in pain, what do? I immediately go to that mantra, right? And like the other mantra from Brett Jones is, more is not better, better is better. And that comes right back to, I quote him constantly at ID coursework. I quote him with my anatomy students in New York. I'm just like, what do you think studying 5 hours a day is going to make you better at this exam? No, better studying is going to make you better at this exam. Why can Bob study for 15 minutes and get an A and I study for 5 hours and get a C? And I'm like, the two are not even related to each other. It's about quality. And I think that the diaphragms, knowing those 7 diaphragms as a mantra is really a good start for any person training anything on the planet. They want to get off the toilet better. Neck long, chin tucked, chest wide, ribs down, hips even, eyes laser forward on target, lips together, teeth apart, tongue on the roof. I just teach them that as a mantra. And then you can hear them saying it in my office. I'm like, what are your cues? And they're like, neck long, chin tucked, chest wide, ribs down, hips even. They say it as fast as I do eventually. But just like you at first, I say, let's just focus week 1 on eyes laser forward on a target. That's not easy. Everybody's eyes are everywhere all the time. Everywhere searching all the time. Boom, get focused. And then add in a cue every week. 7 weeks later, you have all the cues, right? 7 weeks is nothing in the span of our life. Hopefully you're going to live to be 100. So 7 weeks of focusing on one cue at a time. And after that, you got them all down and then you just practice them. And I think that is the stacking you were talking about with Dr. Christie, like that's what it's doing. It's making those 7 diaphragms line up. You're just going to be better for it if you have those 7 cues.
And translating that into the vocal studio, there it is.
You
right?
must.
We're not going to over cue that posterior tilt. We're going to cue the stacking mechanism of our diaphragms.
If you posterior pelvic tilt, it's going to really negatively affect the voice because if you're posterior pelvic tilting, the cervical spine will encourage lordosis will decrease lordosis. If the cervical spine decreases lordosis too much, it's going to constrict the airway by taking the tongue backwards. So you're actually going to create more tension on the larynx and encourage the chances of callus formation, nodular formation, laryngitis. I mean, I would say anatomically, it's not a good position for the voice. So if anything, get neutral.
Another very important structure around this lumbar spine, coming back, bringing it down to the lumbar spine, is our thoracolumbar fascia.
Ah, yes.
Could you run us through a brief overview?
Oh, sure. I love talking about this
Structure.
One of my favorite topics. So the thoracolumbar fascia is, a lot of people know it as its tendon. So what's the difference between a fascia and a tendon? Well, if things start to compress and collagenate, it actually becomes tendinous material. And then we call it an aponeurosis. Aponeurosis is a fancy word for broad, flat tendon. So most people know of the thoracolumbar fascia as the thoracolumbar aponeurosis, which is accurate. The thoracolumbar aponeurosis is a diamond-shaped material upon which 6 structures on each side attach: transverse abdominis, internal abdominal oblique, multifidus, erectors, latissimus, and gluteus maximus. So those 6 muscles on each side. So there's 12 muscles total attaching to that diamond. I call it the diamond in the back, right? But that's not the expanse of the fasciae. Okay, so the thoracolumbar fasciae is 3 major layers with 2 separate laminates. So we have 6 total layers on each side for another 12 of something, right? The anterior layer of thoracolumbar fascia actually is aligning the posterior and anterior abdominal wall, mostly the posterior abdominal wall, and then connecting to the transversalis fascia of the anterolateral abdominal wall. What do I mean by this? Well, this thoracolumbar fascia is connected to this thin fascia that goes all the way from your diaphragm down into the anterior parts of your femur. So if you notice a baby during development in the 3 months supine 90-90 position, they won't really kick much at 3 months. And then at 4 months, they start kicking like a beast. So they are spending 1 full month. They're spending 8 million breaths if they breathe 25,000 times a day. They're spending 8 million breaths earning the right to kick their leg through the anterior layer of thoracolumbar fascia. So a lot of people give a lot of credit to things like psoas and iliacus. And I'm like, I wouldn't give them the primary credit. What's actually happening is the anterior layer of thoracolumbar fascia is connecting to the psoas fasciae, the iliacus fasciae that goes into the anterior part of the femur. So your femur doesn't kick first into flexion. The fasciae tenses first. So it's contractile. And what's attaching to the anterior layer of thoracolumbar fascia is TVA and IAO. Those 2 muscles, transverse abdominis and internal abdominal oblique, they set the tone. They fire first before you kick. Don't ever forget that before you blame psoas and iliacus for everything. People blame psoas for all things. They call it the muscle of the soul. What a complete load of garbage. No, it's not. It is a slave to the thoracolumbar fasciae. So the TVA and IAO, those are what full books should be written about. Now, the transverse abdominis, internal abdominal oblique are attaching at the back to the tendinous part. So the anterior layer of thoracolumbar fasciae has to bind to the middle and posterior layers to create that big tendon, right? So the TVA and IAO come all the way to the back. If you put your fingers above your iliac crest on the back, most people will call that area QL erroneously, right? And that area is actually not QL. That area is transverse abdominis and internal abdominal oblique, coming around to the back to attach to their tendon. So that's just one layer. The middle layer, the M's go together. So the middle layer of thoracolumbar fascia is basically anterior to the erector spinae, posterior to the posterior abdominal wall, posterior to QL. And it's attaching to multifidus and erectors. So that's what you're building this gut pressure with breathing through TVA and IAO, which are exhalation muscles. And that's force transferring through the fascia to tell multifidus and to tell erectors to encourage lordosis. And so the middle layer is for lordosis maintenance. Because again, we talked about from the beginning of this talk to come full circle that lordosis is really crucial to the lumbar spine. Then finally, the posterior layer of thoracolumbar fascia. The posterior layer of thoracolumbar fascia has 2 laminates, right? An anterior and posterior laminate. So the anterior laminate is going to bind with the middle layer of thoracolumbar fascia to form something we call thoracolumbar binding line. And then there's the posterior layer binds with the middle and anterior to form another thoracolumbar binding line. Why am I saying this? Because it's like struts on a bridge, right? We create these struts to create a balance in the bridge that is the spine. So these struts are on either side of the bridge to maintain its sagittal plane position so it doesn't deviate or rotate too much. Let's face it, we have 5 degrees of total rotation in the lumbar spine, and almost all of it's at L5S1. We don't want a lot of rotation there because it'll torque the nerves going down into the lower extremity, as we discussed earlier. So we want it stacked and held. So the thoracolumbar binding lines are the fasciae binding together to create those struts, along with muscles like multifidus, like erector spinae, like QL, like TVA, IAO, that are helping to attach to this fasciae. Then the posterior layer is now taking all this kinetic force that you build through breathing, through lumbar lordosis maintenance, and sending it to the outside world through latissimus dorsi, the strongest muscle in the upper extremity, and gluteus maximus, the strongest muscle in the lower extremity and the entire body. So the posterior layer of thoracolumbar fascia's main goal is to send it to the outside world. Well, the posterior layer of thoracolumbar fascia comes all the way up, actually, not the tendon, but the fascia comes all the way up on the back of the erectors, all the way up to bind to your skull, which is why you watch someone do a toe touch. They can't do a toe touch and they go into neck extension. Or when you see them on the table trying to do, like you said, dying bug, and their head's in full extension, right? They're basically tensing. They're trying to create the tension they can't build from the lumbar spine. They try to build it at the neck, which is inevitably why you see people with lumbar spine problems develop cervical problems. It's inevitable. Like it's really close to the upper 90% of people that have a lumbar spine problem develop a neck problem eventually. So at least in my clinical practice of empirical data. So you really need to understand the fact that this fasciae is helping you to maintain really good lumbosacral spinal stability at your center of mass. It's helping you to maintain good pelvic position. So it's not just all things diaphragm. I know we love the 7 diaphragms, and I'm not talking bad about them. But the second thing we assess in ID, we assess that lateral breathing through rib 7 through 10, and then we assess the ability to release and build tension through those thoracolumbar binding lines, the areas where that fasciae binds. So the point being is that it's not just the diamond you see in the back. It's interwoven all on the inside of your anterior abdominal wall and posterior abdominal wall, and then also all the way up to the base of your skull, which means that core stabilization doesn't just happen locally. It's a regional complex that can happen all the way from the front of your hips to the back of your skull, which makes those cues that we gave even more crucial to maintain for that stacking.
I think it's so important to understand this structure, the thoracolumbar fascia in the anatomy when we're talking about over-cuing a posterior pelvic tilt as well. Thank you so much for being here, for talking anatomy, for talking to us about not over-cuing a posterior pelvic tilt. If the listeners want to get in touch with you, if they want to learn more about you, what would be the best way to do that?
Oh, my email never changes. So it's Dr. Kathy with a K, Dooley, like it sounds, @gmail.com. If you do a Google search on me, usually I just pop right up. And so you can always message me. You can DM me at Immaculate Dissection on Instagram. And then on Facebook, it's just my name, Kathy Dooley. I think it'd be pretty easy to find me. You'll click on it. It's a public page. So if you just click on it, you'll see that I teach at the schools and know that it's me. But if you email me, I send replies back within 12 hours. So I'm very good at keeping up with my email. So I would love to answer any of your questions, or if it stimulated some thought that you want to share, if you want to argue with me, I'd like that too. I welcome all of it. You challenge me, like, let's talk about it and get it out there. I love a good debate. And I understand that this may challenge some of your viewpoints, and that's totally okay. If you're holding strong to a posterior pelvic tilt or whatever we talked about today, that if you just don't agree with it, at least you opened up your mind to listen to the talk and think about the anatomy a little further. I think that when you start to study the anatomy, you'll see that I may not be completely wrong about it.
Thank you so much, and thank you to the listeners.
Thank you. Thanks for having me on. I'm so honored and privileged. And again, if you have any questions, just email over.
Thank you all for listening. If you enjoyed this podcast, tell your colleagues, students, and friends. Subscribe, rate, and please write a review. You can find us on Instagram or Facebook, and feel free to check out my website at www.thevisceralvoice.com for information on programs and upcoming events. I hope you join us next time for another wonderful conversation on the visceral voice.